You guys see my screen?
Yes.
Okay. Okay, so I'm Maddie Hay. I'm one of the PGY3s at the HCA program. Thank you, Dr. Cohen, for this case.
Yeah.
So we have a 73-year-old female. She reports that in the right eye, when she looks at the TV or something outside, she sees a flash of a big red blob. This started at the end of last week, about 4 days ago. She reports that she moved her bed on Thursday, which is big and heavy. And then the next day, she was not feeling good. She's also been itching her eye a lot. She was taking Plaquenil for about 27 years, but stopped it because of her eyes. And she also has palindromic rheumatism. So for her medical history, she's RA, diabetes, hypertension, thyroid disease, asthma, and COPD, and a clotting disorder. She's on Januvia and Xarelto. Vision in the right eye is 2200. No improvement on pinhole J7, and in the left eye 2040, pinholes to 2032 J3, and pressure is normal. So we have the first photo.
Yeah, so we have a photo of the right eye. Media is clear, attention is automatically drawn to the fovea and central macula. We have a large, looks like a pre-retinal and subhyaloid hemorrhage covering the vessels. And, so it's anterior to that, and then the disc and everything else looks normal. Vessels look pretty normal. No torch velocity.
Good.
And then there's a little bit of a subretinal component too on the superior part of that hemorrhage. It looks like it's in front of it.
Can you guys hear okay? Okay. You might have talked a little.
So yeah, all looks
Yeah,
good.
this mic, I mean, I noticed on the recordings, this mic doesn't pick up great if you look at the recording.
Here's the left eye. Maybe a little bit more tortuous vessels here. But otherwise.
Yeah, would you say there's AV nicking?
Yeah, definitely AV nicking.
Good.
And maybe some attenuation of like arterials, but.
Mm-hmm.
I think you know something,
maybe
and that's why you think you see AV nicking. I'm not
maybe a
impressed.
small possible spot there too. Is
You
superior.
can code it.
Fovea.
Mm-hmm. And then just maybe a little dot blot hemorrhage here.
Yeah.
And yep. Okay.
Yeah, so here we have autofluorescence, you see a large area of blockage or decreased autofluorescence, hypoautofluorescence in that area of the hemorrhage. Infrared photo, and then you basically see kind of that same area where you have an increase or decreased reflectivity. And then there's looks like a small area where there's that increase or decreased reflectivity even more along maybe one of the vessels.
Yep. Here's another photo.
Yeah, so it looks like a vertical slice on the OCT going through the center. You can see there's a kind of like a pre-retinal hemorrhage right underneath kind of the ILM on top of the kind of internal retina.
Yep. And then just a little bit of fluid underneath the retina as well. And I think it kind of scans through.
Is it the fluid? Is it fluid or shadow?
Shadow artifact or shadow.
Oh, intraretinal?
Some acoustic shadow. Yeah.
Yeah, it's probably shadow. Big light shadow.
Yeah, more kind of same thing there.
So, sorry, if it is blood, why is it hyper reflective? Is it because of all the material? It's probably.
Because it's bouncing back the light, right? So it's near infrared, but it still picks up, like anything that's dark on the IR should be reflective on the OCT. Cause it's, I'm thinking, is that right?
Well, cause I always, if we have, retinal fluid on diabetic retinopathy, and the fluid is, heme on exam, and then you look at the OCT, it doesn't appear dark.
No, usually you see, it really bounces the light back. The reflectivity, so years ago, I saw a talk where the reflectivity on OCT has to do some with the organization of the cellular structures. So if you imagine a mirror that's like this or like this, if it's like that, it's going to reflect it. It's going to bright. If it's like that, it's not going to reflect it. So some of it has to do with orientation. Some of it has to do with mitochondria. It's interesting. The mitochondria, they look like almost little X-ray reflectors that they throw up in wartime. They have all those membranes in them. And mitochondria seem to probably be very hyper-reflective in vacuoles. It must be red cells. Red cells must be just reflective, either hemoglobin or, the hyper-reflectivity in OCD doesn't necessarily match other things. And I haven't looked into it in the last, I think, 5 or 10 years. So it might be worked out, but I haven't seen any publications on it. But I saw an interesting presentation. Someone showed a very cool video of an OCT of some sort of a frog where it has this ability to move melanin in and out of its retina, and you can see it on the OCT, the line like reflecting back and
Oh,
forth.
cool.
It was very,
Oh, wow.
what's that?
Like, what purpose did nature?
I think for modulating probably light and dark adaptation, maybe. So it was really cool. And there was a very good paper years ago. We break up the 4 outer bands into the RPE, interdigitation, ellipsoid, and external immune membrane. But the interdigitation probably is not interdigitation. It's probably vacuoles. So there's probably your RPE kind of segments where if you take an RPE cell, its position, it's not symmetric. So the outer part of the OCT tends to concentrate melanin vacuoles, and then the inner part of the RPE tends to have these little other vacuoles that have like lipofuscin stuff. So those are probably the two. So it's probably anyway, so the reflectivity, so it's an interesting question, but reflectivity in OCT probably is a lot of things, and whatever, blood is hyper-reflective in OCT. It doesn't necessarily match what you see. It's not, and it's like transparent. Somebody asked me yesterday, I had 2 retinal tears, I was lasering, and they said, how does the laser know where to go? Question, because it depends on what wavelength you're using, we use all different lasers. And it's true that, the eye is remarkably transparent. So OCT should go through everything, but it does pick up certain things. So whatever's not transparent, you expect to reflect back, which would include blood. Okay, go ahead, sorry.
Yeah, I think you're saying about the fluid, usually I guess the fluid is like serous and diabetic.
Yeah, fluid would be transparent, but blood, he was thinking blood, but I think blood would be reflective. Okay, go ahead, sorry.
Okay. So, kind of same.
Yeah, it's a horizontal slice, but really the same thing.
And then we have the left eye.
Yeah, and we have for the left eye, this one is a lot more normal there.
I think we go back to the right eye, kind of focused on that hemorrhage.
Yeah, so these are more like thin slices horizontally.
I'll scroll through because it goes.
Yeah, I would like to see the top area. So I guess you can maybe see within that like a very like a dilated vessel. It's like super dilated there.
Yeah, I think that's picking up a dilated vessel.
Mm-hmm.
It's kind of full.
And
Wrong way. Yep.
And you can see how much of the retina it transverses. It's funny because we talk about these things. It goes pretty deep. It almost touches the RPE, doesn't it?
yeah. There's going almost all the way through the entire retina, most inner retina.
Keep going, I wanna see the deep.
The other way, right?
The other way. Okay.
It touches right there.
Yeah, does it go through it?
Almost. but I don't know if that's, again, it's shadowing.
Yeah,
so you lose it
shadowing.
somewhere. Be interesting to get a high definition. I can quite have the energy to do that. All right, very nice. All right, keep going. You're doing great.
Oh, you broke down and got an FA.
So here's the FA, looks like, it's a pretty, early phase here, so, you have a large area of blockage where that, heme is, and then there's a small area of hyperfluorescence on the vessel, where we were seeing the previous, kind of dilation. And so it keeps moving on, looks like it's getting bigger. And see more.
So then at this point, so you're going, if you go from where it fills, so I think the first one is not full. So if you go like the second one, where it's full, like 28 seconds, maybe that's not there, maybe a little farther, like more, right there, it's pretty full, maybe the next one.
Yeah.
And then do you think from this one, which is 1 minute, to the next one, do you think it's getting bigger, like leaking?
Here, go back 1 second and forward.
Because that's what you're looking like, is it still
I think
leaking?
maybe it's slightly bigger, but I don't know if that's because of.
It's a different view.
But.
I do that, I haven't switched back and forth on that picture.
Yeah, but I mean, it definitely gets bigger from the first one, but,
Yeah. Do you think that's leaking, Reed? It's
No.
tough. Yeah, I don't.
I think the top is more fluorescent and maybe leaking at the top,
yeah,
that cap.
So it's hard to tell, because that's what you're kind of looking for, because you're
It's-
trying to decide what to do with it.
It's, no, I'm not. I know what I'm gonna do with this one, I mean. to
I'll
me,
tell
it's
you what I
obvious.
did, it's a tough choice.
No, it isn't.
All right, keep going, you're doing great.
alright, so yeah, again, you have your late phase FA. These have these small areas where there's, decreased fluorescence, along the inferior arcade, these small kind of punctate areas. Probably are lining up with maybe small hemorrhages. You can,
There isn't a whole lot of baby nicking there.
No, just a little bit. All right, so what's your differential, your findings in differential?
yeah, so, going up in the right eye, you have this large kind of, pre-retinal hemorrhage. Happened after this lady said she was lifting some things, that also has a history of a bunch of diabetes and hypertension. Initially I would think of Valsalva retinopathy versus, busted aneurysm, because you have that little thing, but, and because I guess the only thing is about the blood in 3 layers. So you have some, I guess, pre-retinal and in the retina. So it's pretty close. So those would be my main 2 differentials.
Good.
And obviously, it's always,
And she's on zero.
yeah, she'd also on blood thinners.
Mhm. Okay, so great. I had retinal arterial macroaneurysm, also Valsalva retinopathy, just given the patient's history. BRVO, although you would kind of expect to see more hemorrhages, and we have a good view of that aneurysm on the OCT. You can also think about a diabetic retinopathy or wet AMD, and then other causes that can produce multi-layer hemorrhages include Coates disease. You can get macroaneurysms with that, as well as Irvin syndrome, idiopathic retinitis, vasculitis, aneurysms, and neuroretinitis, although you would expect to see the retinitis, vasculitis, and neuroretinitis as well with that.
I appreciate that, you're the first one to mention Irvan in, I think, 5 years, but I love that syndrome, so thanks for bringing it up.
Yeah, you're welcome.
It's a really good
Okay,
syndrome.
so retinal arterial macroaneurysms. So etiology and pathophysiology. So these are focal acquired dilations within the first 3 orders of the retinal arterioles. Usually it's a second order arterial, and usually it's at a bifurcation of a vessel or at an AV crossing. There are saccular aneurysms in which there's just dilation on one side of the vessel wall, and then fusiform aneurysms where it's kind of focal dilation along the whole 360 of the vessel. And this is caused by arteriosclerotic changes. So you can have chronic cardiovascular disease causes thickening of the arterial vessels on the wall, and this can cause localized ischemia and subsequent linear breaks. And then you get remodeling with intimal collagen, and this causes weakness of the vessel wall, which causes the outpouchings, the focal dilations, or the macroaneurysms. And this is one of the causes of multi-level hemorrhages. So you can get pre-retinal, subilam, prehyaloid, retinal hemorrhages, and subretinal hemorrhages as well. Here on the bottom left, we have kind of a saccular aneurysm, read this bifurcation. And then on the right, it's a little zoomed out, but this is more of a fusiform dilation. So prevalence and risk factors. There's the Beijing Eye Study estimated that about 1 in 5,000 individuals will have a RAM, and 10% of the time it's bilateral. Risk factors, the most well-known risk factor is hypertension. About 75% of patients that present with a RAM will have hypertension. They can also have other cardiovascular diseases, hyperlipidemia. Age is also another common risk factor, especially over 60 years old. And then females are more commonly affected than males. I think it's about 70 to 75% female to male. So symptoms, usually these are asymptomatic and they're found incidentally. However, they can have acute vision loss or a reduction in their visual acuity, metamorphopsia due to macular edema or hemorrhage, and they can also complain of floaters from a vitreous hemorrhage. There are kind of 3 clinical forms of RAM that I found in the literature. There's a lot of overlap between them, though. There's a quiescent form in which there's no hemorrhage or exudate, and these are typically the asymptomatic patients. If there's a hemorrhage, so a hemorrhagic form, they'll have the dilation, the saccular fusiform dilation with a multi-layered hemorrhage, and this usually presents with acute visual deterioration, like in this patient where she saw a big red blob in her vision. And then an exudative form in which there's lipid deposition in a circinate pattern along the lesion with interretinal edema or subretinal fluid. And usually this is a more gradual visual deterioration, but again, there's a lot of overlap between the two, and it can progress from quiescent to hemorrhagic or exudative. So on the top here, we have this classic kind of boat-shaped hemorrhage from a prehyaloid hemorrhage. And then in the bottom, we have an exudative form where you kind of see that traditional hard exudate from previous edema. So on evaluation, do a dilated fundus exam. You usually will see a round or fusiform dilation of an arterial between 100 and 250 microns, and it's usually in the ST arterial or the supratemporal arterial. They can also have telangiectasias, vascular remodeling, or retinal edema. And as we saw in our OCT, the large RAMs can traverse the full thickness of the retina. On FA, the fusiform MAs fill uniformly in the early phase and can have lake leakage. Sometimes the saccular MAs may fill in the middle to late phase as well. And you can also look for a pulsatile filling, which is seen in about 10% of cases. And then you can see staining of the vessel wall, and that's when you'll look for leakage in the later phases. You may also see a filling defect if there's a thrombosis within the vessel or within the aneurysm. On the OCT, you'll see a round hyperreflective lesion within the inner retinal layers. You can also get signal blockage from the vitreous heme, or if there's a vitreous hemorrhage, in which case you may want to consider doing a B scan just to rule out retinal detachment or retinal tear if you have a dense vitreous hemorrhage. And then an ICGA can also be beneficial because it'll allow for deeper penetration through any blood. So you may be able to visualize it a little bit better. Treatment. So usually the treatment is observation at first. Usually these will close spontaneously with resorption of the hemorrhage. However, if they have vision threatening or worsening macular edema or hemorrhage, you can also do a focal laser. So this might be the case where you're looking for a pulsatile leakage on an FA. You may be more inclined to do a laser. You can do direct or indirect application of the laser. From what I was reading, you usually use a moderate intensity, 2 to 3 rows of a large spot size adjacent to the macroaneurysm if you're going to do an indirect. And you can do threshold or subthreshold. There is some increased risk of a BRAO if you cause occlusion of the vessel, like subsequent ischemia or downstream ischemia. and you want to avoid treatment within 500 microns of foveal center. Anti-VEGF also works really well for macular edema. And if you have a submacular hemorrhage, the blood products there can be really toxic to the photoreceptors. So pneumatic displacement of the clot, plus or minus TPA, can be used to kind of squeegee the hemorrhage out of the macula. And if you have a premacular hemorrhage, you can also do a YAG laser posterior hyaloidotomy to just kind of burst that hemorrhage. I don't know if some of the attendings there have any experience or any recommendations that they want to give on the treatment, because it seemed like it was a little up in the air, kind of up for interpretation based on the findings that you have on exam. Then you also want to check their blood pressure if you're concerned, especially if you see other signs of hypertensive retinopathy or choroidopathy. You may want to check their blood pressure and refer them for further treatment of their hypertension with their PCP, or in the case of hypertensive crisis, you may want to refer them to the ED. So prognosis, usually these do regress spontaneously with good vision. However, the hemorrhagic ones have, obviously the quiescent ones have the best chance of good vision because they don't really have any complaints to begin with. And then if they have a hemorrhagic one, those seem to have a higher propensity to regress spontaneously than the exudative ones. And then the worst prognosis is with persistent macular edema or subretinal hemorrhage. As I said, the hemorrhage under the retina is really toxic to the photoreceptors. And you can have vision loss that's secondary to macular edema or occlusion downstream, and that can lead to retinal ischemia or a hemorrhage, obviously, if it ruptures. And here are my references. And that's
That was
it.
very good. Could you email me that if you haven't already?
Yes, I can. I will.
I'll keep that. So what would you do, Reed?
I observe.
Yeah, I observed this. I tend to observe them. There's a paper from Wills that I think is pre-internet. I can never find it, where they did a retrospective study and they split. They found the ones that had hemorrhage were more likely to regress than the ones that did not. And this was a pre-retinal. This patient, I didn't want to, because I think it's the right thing to do. She didn't do well. So I didn't bring the rest of the slides, because I didn't want you guys to think you should treat everybody. She actually re-hemorrhaged subretinally about a month later. And now the blood's gone away and she has bad vision. So I mean, in medicine, I so wish I had a time machine. I mean, you kind of have to put your cards down. You guys will get that.
Yeah.
And it sucks. I mean, I lose sleep lately. I've had a couple patients not do well, but you have to sort of look at the patient, decide what to do and do it. And then,
You would have given her a scotoma. It is almost, you cannot stop laser. That's the problem.
I do. Oh, so my laser for these is not, and I think it's not yours and it's not everybody else's. What I was thinking,
Are
right?
you indirect?
No, I do direct. I do big slow. So I do 500. If I get 1,000, I'll do it. And I'll do like a 1 second spot on very low energy.
Wow.
So like a 200 milliwatt, 1 second, just sort of, cook it a little bit. But I've done that. But again, when I trained, Mary Lou Lewis would have been a very famous retina specialist, but she didn't work in the same department as Dr. Gass. And she said in her career, she had never lasered one, and they all did fine. And there were some other people who
They don't always do.
No, that's what, yeah. So,
So if they bleed under the RPE, they can look like a melanoma. The color of blood under the RPE is very dark. It's not red. It looks very melanoma-like, and it's very hard to tell.
Ever been on this Xarelto?
That's what I wonder if I should, in retrospect, like I'm so good at rethinking all of my decisions. But in retrospect, if I saw someone on Xarelto, maybe that person should be lasered. But I can tell you, I've never ruptured one with the laser. I operated one once that I'll never forget. Back when we operated, we used to operate and we'd evacuate subretinal hemorrhage. And I got in there and I was getting the subretinal hemorrhage. Everything's going pretty well. And then all of a sudden it just broke. The aneurysm. It's just like this pulsatile hemorrhagic thing in the vitreous. You're sitting there in the middle of surgery looking at this thing like blood shooting all over the place. And so you had to laser it. But the thing is, in surgery, you don't have the view. It's not like at the slit
And the
lamp.
laser's not very.
Yeah, and the
precise.
laser's not as good. So you pretty much just blast the hell out of the area. And I'm sure it was not a happy.
They can cause a lot of trouble if they're downstream. So that you're not going to occlude
Oh, a macular.
Macula-
foveal
macula.
vessel, right?
then I don't mind treating them, because peripheral occlusions, people don't notice.
Right.
Oh, you
And
know,
if there's macular edema, I have one of these growing. It's amazing in your
Well,
macular degeneration patients. If you, I've had a couple of macular degeneration patients, so I'm treating, they're doing okay, then all of a sudden they start going backwards. And I'm looking at them, and then, you know, sometimes not that visit, sometimes 2 or 3 visits later, I look around, it's like, oh, there's a macroaneurysm, and then you see it, and then you just, sometimes those I'll treat.
but these can let loose and cause terrific havoc. They
Right,
usually don't, and that's why Mary Lou Lewis could say that,
yeah,
but,
all right, so who's gonna go
so if
next?
they're downstream, I like to laser them, they're fun.
Yes,
The problem is I almost always occlude the vessel.
all right, Kevin, why don't you do yours?
I had a quick question. Could we go back to like the first colored fundus photo?
You have to do that now.
You just quickly, like very quickly identified,
Yeah,
Yes.
let me try and go back. Hold on just a
and
sec.
I just I wouldn't have called it pre-retinal off the bat, and I was wondering like what.
Oh, yeah, the OCT shows this pre-retinal. I mean, it does it, the fluorescein does too. It obscures the vessel.
Cause I'm always looking for that like classic boat shape, hemorrhage.
Well, it doesn't have time to layer.
Mhm.
I mean, it's a little fresh. I think her vision loss was pretty recent, wasn't it?
Yeah, I think
It's like,
Dave-
within a week.
Right, yeah, and she may line her back a lot.
I thought the border was interesting. It looks like.
Right, it's a little bit of subretinal. I think that it's just lightening up. If you look at the OCT, the blood, some reason or another clustered in the middle. Yeah, it does almost look like there's another layer at the border, who knows?
Oh, yeah, I was reading that this kind of double ring sign
Right.
is indicative of like a sub ILM hemorrhage and a pre-hyaloid.
Oh, interesting, maybe, because it
That
does
like
look.
this one and then this ring here might be like both of those, but I couldn't really tell that on the OCT, so.
And then one more question. Yes.
Posterior YAG,
Yeah, I don't do that.
that sounds like a,
People do, you can do an Oregon. For pre-retinal hemorrhages, I don't see the point in messing with them. The prognosis for pre-retinal hemorrhages is 90, I mean, there's always outliers, it's 99% good. I don't see any reason to go blasting out with the laser. But the point is to release the blood into the
right,
vitreous and get it away from the retina, but pre-retinal blood is benign. So what's the point? But people do it. I think they do it because they gotta present at meetings and stuff. You know, hate to be like jerky like that, but sometimes those things come up.
isn't
Like if you tried to get that past an IRB or like an FDA study, like I'm gonna pre-retinally hemorrhage, I'm pre-retinally laser people with a benign disorder.